So, good morning, all. Greetings from Jaipur. I am Dr. Sanjeev Kumar Sharma. Today, the topic allotted to me as a pain medicine specialist or pain physician. So, I do a lot of RFA cases in facial pain. So, I've been allotted topic like targeting facial pain with radio frequency ablation. So, now coming to what is RFA and what is the history of RFA. So, first of all, if we see the history of RFA, if we see, we all know Mr. Nikola Tesla. He invented the Tesla coil in 1891, and he created high frequency and high voltage currents with the help of Tesla coils, and he tried to convert this currents into heat energy. So that was the starting point for the role of RFA. In 1931, Dr. Martin Krishnan tried to put some electrodes into the brain, trigeminal ganglion area, and first of all, he did give the treatment for trigeminal neuralgia. In 1950s, Dr. Sidney Aronow and Dr. Bernard Kosman, they made the first commercial radio frequency ablation device. They used the standard electrodes to produce the targeted or precise thermal lesions via controlled radio frequency waves. They were the first persons to control the RFA probe tip temperature actually. So they were the first ones. In 1973, neurosurgeon Dr. Clyde Norman Shelley, he introduced modern day percutaneous RF electrodes for lesioning the articular nerves. 1996, pulsed RFA, that is a new type of RFA, has been introduced. In 2000, cooled RFA and other image guided systems like ultrasound guidance, fluoroscopy guidance, they were introduced. Now coming to RFA, it provides a longer lasting relief of chronic neuropathic pain by disrupting the pain signals by thermal neurolysis. Okay, so RFA types, if we see, it is usually three types: conventional RFA, in which you use either monopolar or bipolar RFA, cooled RFA, and pulsed RFA. So cooled RFA is not being used in cases of facial pains because it is produce a bigger lesion size, which could damage or other and which could lead to damage of other surrounding structures. So cooled RFA is being used in cases of joints like knee joint, hip joint, other structures. So we don't use cooled RFA in case of facial pain, but conventional RFA and pulsed RFA are being used in facial pain. Now coming to physiological basis. So this is a normal, this conventional RFA works like an electrical circuit in which we can see a RF generator machine which is being connected to electrical supply. And this RF generator is being connected to the RF probe, which is being inserted into the body part or a particular nerve area, which produces high frequency radio frequency waves. These high frequency radio frequency waves, they produce electromagnetic field at the tip of the probe, which causes the water molecules to vibrate, and heat is generated through the friction. Now, this results in increase in the surrounding temperature of the probe tip. Nowadays, these RFA machines, the probe tip temperature can be detected by the machine, and gradually we can adjust the tip temperature by adjusting the voltage of the machine. So we keep on increasing the volts of the machine, and the more radio frequency waves are being produced, so more is the temperature tip. So we can control the tip temperature by controlling the RF machine knob. So what does RFA does? It produces the grade 3 nerve thermal lesion, that is the myelin sheath, the axon, and the endoneurium are disrupted. Later on, it results in Wallerian degeneration. So the nerve is not able to produce the pain then after that thing. So in RFA, small unmyelinated A delta and gamma fibers, they are heat sensitive because they're unmyelinated. So they are more readily damaged or more readily ablated by RFA. In cases of large myelinated A beta and A alpha fiber, that is the motor fibers and the touch pressure fibers, so they are heat resistant. So at very high temperature only, then these can be damaged. So we can say the RFA is a pain selective procedure. So pain fibers are selectively damaged or heat ablated by this RFA. In conventional RFA, we use high frequency AC current at the range of 0.1 to 1 megahertz. After inserting the RFA probe in a particular nerve area, then we do sensory stimulation and motor stimulation, and we check that we are at the right side, and then we do RF ablation. Now there are some factors which predict the lesion size, the heat lesion which is being produced at the RFA probe tip. So the various factors which affect are the active tip length. So the distal part of the this RFA probe is uninsulated. So we can see that proximal part is insulated, that distal part is uninsulated. So this insulated part gets heated up and it produces the heat lesion. So the tip length, more is the tip length, more the larger size lesion is being produced. Gauge of RF cannula, we use needles gauge from 17 gauge to 21 gauges. More is the gauge of the cannula, more is the bigger size lesion is being produced. Next is if we inject lignocaine or normal saline before doing the RFA, then it creates a bigger lesion size because the heat dissipation is more bigger in the size. If we increase the temperature and duration of lesioning, that the heat lesion size will be bigger in size, but there is a difference in there that if we keep on increasing the temperature and duration of the lesioning, it will produce the local charring of the tissues, which will impair the heat transmission to the nearby tissues. So what it happens that the heat, that this charring of tissues, it limits the size of the lesion size. Shape of RF emitting device. Some RFA cannulas are straight in shape, some are curved, some are venom. This is V-shaped cannula. So this straight shape, they produce elliptical type of heat lesion. This curved and this V-shaped RF cannulas, they produce a more spherical type of heat lesion. So the bigger lesion is being produced. Now coming to pulsed RFA, as we can see, then conventional RFA heat lesion is being produced, but sometimes this heat lesion can can damage our nerves. For example, if you are using this RFA in case of some mixed nerves, so in that case, the motor fibers can also be damaged. So, and in those cases, we use a pulse RF. What happens in pulse RF? The radio frequency waves are given in a is pulses, that is 20 millisecond duration, and then later on there is a long silent phase of 480 milliseconds. So this intermittent pulses and long silent phase between the pulses, it leads to the overall heat reduction. Heat is being produced, but overall heat reduction is low and keeps the temperature tip of the probe at below the 42 degrees Celsius. So what it causes, that there is a electromagnetic field in that area is being generated, which causes the neuromodulation. So this the main principle of working of pulsed RF is neuromodulation. So neuromodulation, it causes disruption of sodium and calcium pumps in DRG, that is the dorsal root ganglion in the spinal cord and other areas, minimizes the microglial activity which are responsible for pain perception as well as pain propagation. It alterates it causes alteration of gene expression involved in pain pathway, that is the C-FOS, CGRP, and pro-inflammatory cytokines. So overall, pain production and pain propagation is being affected by this thing. Also, it improves the endogenous pain reduction pathways, that is the endogenous opioid pathway. So it increases that pathway. So pain perception is gradually goes down. In pulsed RFA, the electrode temperature is maintained at 42 degrees Celsius, so though there is no neural structure is being damaged. So pulsed RF we usually use in cases of V1 trigeminal, because in this V1, if we do conventional RF, then it could lead to corneal hypoesthesia or corneal ulceration could be there. So pulse RF is being preferred in that cases. In cases of peripheral nerves or mixed nerves, we use pulse RF. In cases of occipital nerve, in case of occipital neuralgias or tension headaches also, we use pulse RF mainly. But in case of glossopharyngeal nerve, which is a mixed nerve, we use pulse RF. Now coming to contraindications, if the patient has already got implanted cardiac pacemakers or DBS, they can their functioning can be hampered with the use of RFA because electromagnetic fields is being created by RFA. So RFA can be done if these devices are put on asynchronous mode. If the patient is having uncorrectable coagulopathy is there, then we have to correct it first. We have to keep the INR between 1 to 2. Platelet count should be more than 50,000. Anticoagulant medicines has to be stopped or adjusted as per the ESRA guidelines. If the patient is having local or systemic infections, we have to control them, or either we don't have to do the RFA. Hemodynamic instability, we can't do it. If there's a psychological overlay. So if the patient is having a good amount of stress or depression or anxiety and all those things are there, and if he or she is not able to perceive the pain in correctly, or in that cases, if we do RFA also, the patient will not able to tell what are the actual benefits of RFA. So in that case, we should avoid the RFA. Now coming to complications, local pain or swelling could be there because we are inserting an RFA cannula or needle. So localized tissue trauma or muscle trauma is being there. So local pain and swelling would be there. Hypoesthesia over affected dermatome. Since we are ablating the sensory now, so little bit of hypoesthesia is always there. Local skin infection, cellulitis could be there if aseptic precautions are not being followed properly. Skin burns could be there. So we should try to keep the target structure, the distance between target structure and the skin surface should be more than 2 centimeter. So in that cases, we use a long pathway of the needle. We don't do directly. We should usually use a long pathway so that we should avoid the skin burns. Motor nerve injury could be there in cases of mixed nerve RFA. Painful cutaneous dysesthesia and painful neuritis are being nowadays are seen less because we usually these are due to nerve inflammation post RFA. So we usually put some amount of steroids and local anesthetics after the procedure so that these don't occur. Some technical difficulties we could identify, we could encounter, that is some age-related osteophytes, degenerative changes, or some implants could be there in the pathway of our needle entry, so or at the target site. So these can hamper the exact localization and doing the procedure in the proper way. Variability in nerve distribution could be there. I could say one example. I was trying to do gastric ganglion RFA for the V3 area. I put my needle in a proper way. I checked in my fluoroscopy views, and all those things were perfect. Even I checked from the sensory motor stimulation also. It was going good. But after the procedure, the patient developed some amount of corneal hypoesthesia also and some diplopia also, because there was some the orientation of the nerves in the trigeminal ganglion was such the way that the effect of RFA went over to the V1 and this fourth cranial nerve also. So these could be some factors which we should also see. Now coming to common steps of RFA. In all types of RFA procedure, we follow these common steps. So 1 to 2 weeks before planning the RFA, we do image guided, that is fluoroscopy guided or ultrasound guided diagnostic lidocaine nerve block. If the patient is having more than 50% reduction of pain score, then we can go for RFA. On the day of RFA, we put the patient on conscious sedation, that is IV midazolam and fentanyl. Grounding pad is placed on the same side of the area. Image guidance either by ultrasound guidance or fluoroscopy guidance we do. We don't do nowadays with the under the landmark guidance. We don't do that nowadays. Skin and soft tissue are superficially anesthetized with lidocaine. We select appropriate length and active tip size of RF needle according to the target site and the area. So accordingly, we select the needle tip. Needle placement over the target anatomic sites under image guidance is there. Then we remove inner solid from the RFA cannula and then insert RFA probe electrode into the needle. Then we do sensory stimulation and motor stimulation and check whether we are at the right place or not. If we are not at the right place, then little bit repositioning of needle being required. Then we do give deep local anesthesia. We inject around 0.5 ml of lignocaine or bupivacaine, little bit about on that it induces local anesthesia at that place. And then we go for conventional RFA. In conventional RFA, we give 3 cycles of incremental temperature at 60 degrees Celsius, 70 degrees Celsius, 80 degrees Celsius, 1 minute each. Followed, if you want to go for pulsed RF, then we keep temperature at 42 degrees Celsius. 45 volts is being set in the machine, and pulse duration and pulse frequency are being set, and the total duration of pulsed RFA is usually between 4 to 8 minutes cycle. Post RFA management, RFA has been done, then we apply ice packs over the localized area so that the swelling and the localized pain is reduced. Rest to affected area, avoid strenuous physical activity. NSAIDs can be given for 5 to 7 days for localized pain. Hypoesthesia and abdominal sensation could be there for 10 to 15 days. So I always tell to my patient that in next 10 to 15 days, you will feel some abnormal sensation. You should ignore them and don't call me or text me every 2 to 3 days that you are having these sensations. After 15 days, these abnormal sensations usually settle down and the good amount of pain relief is a patient has after that. Now, if we see multiple facial type pains could be there. So what are different facial pains and what intervention we can plan, we can see in this chart. So if the patient is having unilateral episodic orofacial pain, It could be trigeminal neuralgia type 1 or type 2. It could be glossopharyngeal neuralgia. So in case of trigeminal neuralgia, we do glycemic ganglion RFA, or we can go for peripheral nerve, that is maxillomandibular nerve RFA, or the peripheral branches, that is the supraorbital, infraorbital branches, we can go for RFA or pulsed RFA. In cases of trigeminal autonomic cephalgia, that is the cluster headache or sphenopalatine neuralgia is being there, we can go for pulse RF or even RFA also. In cases of persistent orofacial muscle pain, or in case of persistent idiopathic facial pain, we usually do go for sphenopalatine ganglion pulse RF or RF cases. In cases of PHN, that is a post-herpetic neuralgia in V1 distribution, we go for supraorbital nerve pulse radiofrequency. In cases of post-traumatic trigeminal pain, we can go for selective nerve branch radiofrequency ablation. In cases of chronic, cancer pain due to malignancy, then we can go for selective nerve RFA cases. In cases of headache, also like tension type headache, also in case of occipital neuralgias or supraorbital neuralgias, we go for RFA. So the comprehensive or management of pain is in which we use a multidisciplinary approach for treatment. Along with the pain medicine specialist, a role of dentist, neurologist, neurosurgeon, clinical psychologist is always there for management of neuropathic orofacial pain. Now coming to trigeminal neuralgia, so I think it has been discussed a lot. So trigeminal neuralgia is one of the most painful conditions which is known to mankind. I see a lot of trigeminal neuralgia cases. They are very painful condition. So they have very sudden, unilateral, severe, brief stabbing pain in the fifth cranial nerve distribution. So we can see this is the trigeminal ganglion, which is coming. This is the dorsal root, trigeminal root entry zone. Some aberrant vessel could be present. It could be shown in the MRI findings also. In that cases, MVD, microvascular decompression, helps, but only in young cases. But if this compression is more than 4 to 5 months, then MVD process sometimes doesn't help in these cases. So RFA of glycemic ganglion helps in these cases. So from this trigeminal ganglion, we see a V1, that is ophthalmic branch, V2, V3 branches. So in cases of some pain or injury due to the tooth extraction or some damage to peripheral nerve, post-traumatic trigoneuropathy pain could be there, then we can go for selective nerve block, or RFA could be there. In cases of oral cancers, involvement of maxillary or mandibular nerve, we can go for selective RF of these nerves. In cases of unidentifiable pain could be there, then we can go for a diagnostic pain, this nerve block. And if the diagnostic nerve block has got good relief, then we can go for RFA. These interventions are being done only when appropriate clinical management or conservative management has been tried, but the patient is not having relief, then we can go for these interventions. Now coming to decision making. So when should be any intervention should be considered if the medical therapy which we are already been giving to the patient, it has failed. We are keep on increasing the dose, but the patient doesn't have any good relief, or the side effects are become problematic for the patient. Then in cases we can go for interventions. Frequency of acute exacerbation. There's a repeated, even on good amount of medical therapy, the patient have acute exacerbations of pain. We can consider duration of symptoms. If the patient having a long duration, more than 1 to 2 years, the patient is having getting tired of this pain, then we can go for interventions. Which intervention should be done? It depends on age and health of patient. RFA is such an intervention which can be done. I have done RFA for trigeminal neuralgia from 16-year age to 90-year of age. So I have done case of 16-year girl also and 90-year-old lady also. So it is very safe in that cases. Willingness to accept facial sensory loss. For in case of trigeminal RFA, always say that the patient will have some amount of cutaneous hyperesthesia. So it should not be problematic for the patient. But if patient refuses, then I go for pulse RF. If the patient has gone for previous procedure for trigeminal neuralgia like MVD surgery, I receive patient from who had already gone an MVD surgery has been done, previous blocks have been done, but RFA can always be done in such cases also. Invasiveness of procedure, if we see MVD procedure, that is a surgical procedure is there, but RFA and all these procedures, these are percutaneous, minimally invasive procedures, so they can be easily done. Desires of patient, cost effectiveness of patient, and experience of surgeon also factor factors which should be taken in account while deciding which intervention should be done. Now coming to peripheral nerve blocks or RFA. So before doing RFA, we always do a diagnostic nerve block. The patient having good relief, then only we can go for RFA. So in trigeminal peripheral branches, that is supraorbital, supratrochlear, infraorbital, mental nerve, auriculotemporal nerve can be targeted. Peripheral nerves like V2 maxillary and V3 mandibular could also be targeted. The benefit is that it has a diagnostic role also and prognostication that whether RFA will be work in that cases or not. And usually the nerve blocks and these peripheral nerve RFA, they had good amount of relief for 3 to 6 months. We can easily see to the patient. Now coming to anatomy, we can see the supraorbital foramen is over here and it contains the supraorbital nerves and vessels. Infraorbital foramen is over here and we can over the cheek area and it contains infraorbital nerve and vessels. Mental nerve and mental vessels is over here at the just below the angle of mouth over this area. And this auriculotemporal nerve is in front of the tragus of the ear. So we can target accordingly. So supraorbital nerve, for supraorbital nerve, for V1 trigeminal neuralgia or post-herpetic neuralgia, I usually do under ultrasound guidance. I place my ultrasound probe over in transverse view over the brow of the patient, and we can see there is a bony break over here. This is the bone and this is bony break over here. And if I put color Doppler over here and I can see the vascular pattern over here. So here it is the supraorbital nerve. I can bring my RFA cannula from in this direction and target here there. First of all, I do sensory stimulation, and after good amount of sensory stimulation, then I can go for RFA. For infraorbital nerve, I place my ultrasound probe just below the eye over the cheek area. I can see a bony break. We can see this is the bone area and we can see a bony break over here. We can see blood vessel in the color Doppler and we can target over this area. For mental nerve, we place our ultrasound probe just below the angle of mouth area and we have to find the bony break. So we can see a bony break over here. We place our color Doppler over here and we can see there is a color Doppler pattern, vascular pattern is there, and we can place our needle, check for sensory stimulation and go for the RFA. For auriculotemporal nerve pain, we have to place our probe in the transverse view just above and just in front of the tragus of the ear, and we can see that this is the auriculotemporal artery, superficial temporal artery is being over here, and this is the auriculotemporal nerve. So we can see this is the vascular pattern which is being seen, and we can target the nerve which is along just usually around the artery. Coming to maxillary nerve. So maxillary nerve and mandibular nerve, they have to be approached through the coronoid notch area. So we can see that this mandibular nerve comes out through foramen ovale and goes down, and maxillary nerve comes out through foramen spinosum, rotundum, and it goes into the sternocleidomastoid fissure. So in this view, how we will do? We will place our ultrasound probe over the coronoid notch area, and we will insert our needle from the posterior to the anterior side, and we will go and hit the lateral pterygoid plate. We can see this needle is coming like this, and it is going to hit the lateral pterygoid plate, and over here, this is the pterygopalatine fissure area from which the maxillary nerve enters into the pterygopalatine fossa area. So we have to find the nerve over this area. We have to do sensory stimulation, and we have to find it, and we have to target it. Going for the mandibular nerve. So mandibular nerve, we will place our probe in the same fashion over the coronoid notch area. We will place our needle from anterior to posterior direction, and like this red needle is the for the mandibular nerve. With the needle is coming down, and just posterior to the lateral pterygoid plate, we can find the mandibular nerve. We have to just adjust our needle and find the mandibular nerve by sensory stimulation. Now coming to complications, nerve injury could be there, paresthesia, dysesthesia could be there due to nerve injury. Sometimes it happens, sometimes it doesn't happen. We have to explain the patient. Numbness over face due to radio-frequency heat lesioning of the sensory nerve. Some amount could be there, sometimes it is there, sometimes it goes away slowly. Skin sloughing and fat necrosis could be there. Swelling and localized hematoma could be there. Intravascular injection could be there. If you are going for the maxillary nerve, you can inject into the maxillary artery. And if you are going too much superiorly, then you can inject into the intraorbital foramen or into the eye area. So it could lead to temporary ophthalmoplegia or diplopia area. If you are going for the mandibular nerve block, you can, if you are going too much posteriorly, then needle can enter into the pharynx or it can cause mucosal injury. Now coming to Gasserian trigeminal ganglion RFA. So indication is the severe pain which is not responding to the medical management, patient who is unwilling for surgical procedure, and patient who had failed the previous procedures. So anatomy, if we see, this green one is the Gasserian ganglion, if we see from the inside. So this is the mandibular nerve, which is V3, which is coming out of foramen ovale. This is the V2, and this is the V1. So this is the similar which is being seen. So this is trigeminal ganglion, V3, V2, and V1 area. The Harter's technique for Gasserian ganglion RFA. So first of all, we have to find the foramen ovale. The foramen ovale can be found out by doing the submental view in fluoroscopy. In submental view, we adjust the fluoroscopy, that is around 30 to 40 degree in the caudal view and 15 degree in the ipsilateral oblique view. So in this way, we can see that foramen ovale is oval in structure, which is present between the maxilla and the this mandibular condyle. Okay, so we can find it. Now position will be supine with little bit of neck extension. Point of entry of the needle should be approximately 1 to 2 centimeter lateral to the angle of mouth, which will be targeting the midpoint of pupil in the AP direction, and if in the lateral direction, if we see that the needle should be targeted towards the tragus area. So as we can see, the needle tip has entered into the foramen ovale and entered into the this ganglion. And if the needle tip is up to here, then the V3 RFA will be done. If we are going more proximally, then V2, and if we are going more superior medially, then V1 radio frequency can be achieved. This is lateral view. If we see in this lateral view, this is the sella turcica, and this is the dural line. This is the clivus area. So the clivodural line. So the needle tip should not cross the clivodural line. Otherwise, we will puncture the dura and we can enter into the midbrain area. So this is the base of the skull. Foramen ovale was here. So needle tip has entered into this thing. Okay. So these are the final picture images we have to achieve during the fluoroscopy. This is the foramen ovale in which the needle tip has entered, and we can see the needle tip has entered into the foramen ovale and going up to the clivodural line area, and we have to go for sensory motor stimulation. So outcome, if we see, it complete pain relief is being seen in 83 to 99% of patient. Recurrence rate is around 20 to 40% in 3 to 4 years. Dysesthesia, sensory loss can occur in 6 to 20% of patient. Motor weakness in 14% of patient. Loss of coronary reflex in 3 to 8%. When the needle tip is at V1 area, it could be there. Anesthesia dolorosa is a very rare complication. It is very, very low rate. Coming to level of evidence, as per the World Institute of Pain, the recommendation is low to weak, but practically if we see, the patient has got a good relief in not 100%, but we offer a good amount of relief to these patients. So level 3 evidence as per the American Society for Interventional Pain Practice. Now coming to sphenopalatine ganglion. This sphenopalatine ganglion, it acts as a relay center between the sensory fibers and autonomic fibers. So it indicates that the sensory, that is the pain signal from the trigeminal component, as well as the autonomic component, that is the nasal congestion, lacrimation, ptosis, and redness. So this sphenopalatine ganglion stimulation, it plays a very important role in case of atypical facial pain or persistent idiopathic facial pain. So in these cases, they're different from trigeminal neuralgia, that they are having constant, dull aching and burning type of pain with some autonomic features like nasal congestion, lacrimation, etc. In cases of cluster headache or autonomic cephalgia, the patient is complaining of severe retroorbital pain or facial pain with some autonomic features. In these cases, we target for the sphenopalatine ganglion. So sphenopalatine ganglion is a very complex anatomy. There are a lot of nerves coming and going through this sphenopalatine ganglion. So we can see the sphenopalatine ganglion is over here. It is inside into this pterygopalatine fissure area. This inverted vase appearance. So it is inside that thing, and lot of nerves are coming and going out of this thing. So in this sphenopalatine ganglion RFA, we insert our needle through the coronary notch, and we have to target. This is the pterygopalatine fissure area, this inverted vase appearance, and we have to target the superior third of this pterygopalatine fissure area, and we have to go inside. And in the lateral view, in the AP view, we can see the needle tip do not cross the lateral aspect of the middle nasal terminate level. So after doing sensory motor stimulation, then we can go for radio-frequency ablation. So in this sphenopalatine neuralgia, we go for pulsed RF and radio-frequency ablation also, as per the evidence, because the evidence, they have very low to weak evidence is being there. The main reason is that these cases are very less in number, and also the interventions done are also very less in number, and the reported the published literature is also very less in these cases. So the overall the literature evidence is very low in these cases. Many studies are being required in these cases. So coming to glossopharyngeal neuralgia, this is last topic. So in glossopharyngeal neuralgia, there is a paroxysmal of pain in the sensory division of 9th cranial nerve. So the patient will having the pain at the just below the ear, also at the angle of jaw, base of tongue, tonsillar fossa, and the lateral part of pharynx area. It could be triggered by a neck rotation, swallowing, chewing, and other activities. It could be sometimes it could be due to some Eagle syndrome, that is long styloid process or calcified styloid ligament. So first of all, we will do diagnostic blockade with the use of ultrasound guidance. We can see this is the mastoid area, this is the styloid process, and this is the angle of mandible. So between the angle of mandible and the mastoid process, just in between, there is a styloid process. So we have to place our probe over here in this fashion, and we have to target needle from this area to this area. We have to try to hit the styloid process. The depth should be not more than 2 to 3 centimeter. 2 centimeter, 1 to 2 centimeter is the approximate depth of this structure. So we can see this is in this ultrasound image. This is the submandibular gland area. This is the angle of mandible. The needle will come from like this to this, and we have to hit the styloid process over this area. Usually the glossopharyngeal nerve lies posterior medial to the styloid process. In fluoroscopy guided approach, we have to find out this mastoid process, this angle of mandible. Styloid process is over here. So in this thing, we have to, in the lateral approach, we have to target and hit the styloid process and go little posterior medial to it. Depth is around 1 to 2 centimeters, so we have to adjust the course of needle accordingly. Then we have to inject the contrast, see whether there is no vascular uptake is there, because this carotid vessels are nearby their thing, and then we can go for pulsed RFA. Since glossopharyngeal nerve is a mixed nerve, we can't do conventional RFA. We have to do pulsed RFA only. Now evidence, if we see, short-term relief is seen in 84 to 93% of patient. Short-term relief is seen, very good short-term relief is seen 84 to 93% of patient. Long-term patient, if we see at the 5 years, it is around 73% of patient. For 10 years, it around 54% of patient. Main important thing is that there is a significant decrease or complete discontinuation of neuropathic pain medicine like pregabalin, oxcarbazepine in these cases. In case of secondary GPN due to oropharyngeal cancer or some nerve compression is being there, then pulse radio frequency is seen that for at least 3 to 9 months period, 92% patient have good amount of pain relief, we can see. And also we need a lot of RCTs, because these cases are already rare. That intervention treatment is already very rare, and the research is also being very less published. Thank you.